Good evening. Thank you for coming out. My name is Dr. Joe Galloway. I'm a bariatric surgeon and surgical specialist here at the Mobile Infirmary. And we're going to be talking tonight about surgery for morbid obesity. The insurance companies go by a formula for the body mass index, which is the BMI, to determine your obesity status. Up to 25 is considered normal, 25 to 30 is overweight, 30 to 40 is obese, and 40 and above is morbidly obese, and that's the category we operate on. And the reason for that is this is too much weight to try to lose on your own, and you need some help, such as that with surgery. The word morbid means it's harming your body. It's harming your body in several ways. One, your heart has to pump harder to pump all that blood into that extra tissue. That leads to high blood pressure. High blood pressure, of course, wears out organs in your body, such as your eyes, your kidney, your liver. Much more prone to have heart disease because your heart's working that hard. Being this overweight is also a high indicator of developing diabetes if you don't have it already. Good news is the surgery for the morbid obesity is the only known cure for diabetes. Sleep apnea is where the weight on your neck, when you go to sleep and relax, the weight on your neck actually collapses your breathing tube, cuts off your breathing, which cuts off oxygen to your brain, which is very dangerous itself. You also, with sleep apnea, don't get a very restful sleep. So you wake up in the morning and you're actually tired. We get some of that weight off, your neck doesn't collapse like that when you go to sleep. You actually wake up rested after having a good night's sleep. Of course, there's lung troubles because you have to breathe and expand all that extra tissue and get oxygen to all that extra tissue. It's been also associated with polycystic ovary disease. I get referrals from OB/GYN doctors about weight loss in patients that are already experiencing polycystic ovary disease to try to help that condition. And of course, it wears out bones and joints, such the orthopedic surgeons tell us. For every pound we take off up here, take 6 pounds of pressure off your knees and your ankles when you're standing and walking. There's also more pressure on your back because most people have more of the weight to their front. They're using their back to support all that weight, and it gives them chronic back pain as well. Believe it or not, some cancers have been associated with morbid obesity, and here's a list of these. So in other diseases, much more prone to get gallbladder disease. So there are a lot of things that you might not figure are harming your body just based on this excess weight. What does obesity look like? The picture on the far left of a green is actually a silhouette of what a normal body habitus should be. And as you can see, going all the way to the far right, the red, what morbid obesity looks like. Quite the difference on those silhouettes. Maps showing obesity, the colors here, the yellow, the green is best, yellow is moderate, and toward orange and red is the worst. Morbid obesity has only really become a pandemic here in the United States in the last 15 or 20 years. And we're going to show you as we scan through a few different years of what it's looking like. On the next slide, you can always see in our beloved state and neighbors that the red is starting to show up. Wait a few more years, more red comes up, and now you can see on this picture how most of the country is turning red, and we're dark colored, which is the worst for the obesity. And again, that's just only happened in all of our lifetimes. It's really become pandemic. Now, there are a few treatments for obesity and morbid obesity. Most of y'all are very familiar with diet, exercise, and medication. Not working for y'all, or you wouldn't be here to hear about surgery for morbid obesity. It's very difficult to cut back without some help. Very difficult when you do have knee pain and foot pain and back pain and you're heavy to get the proper exercise. And then, of course, all medications, whether they're doing something good, they always have side effects as well, and a lot of the diet medications you've seen over the years have been taken off the market. So we do have surgery for morbid obesity. We offer several options. To qualify for surgery, most insurance companies require you to have a BMI of 40 or greater. Some will lower that BMI down to 35 if you have comorbidities such as hypertension, diabetes, sleep apnea, joint problems. Some of them require those problems to be uncontrolled even on medication, however, so it depends on your insurance policy, but for the most part we're talking about a BMI of 40 or greater. Here's what the anatomy looks like inside your body. When you eat, food comes down your swallowing tube and then into your actual stomach. Your stomach's about the size of a football, and your stomach just holds the food. Your stomach doesn't absorb nutrients, it doesn't absorb vitamins, it doesn't absorb the calories. Your stomach holds the food and slowly lets it go into your intestines where it is absorbed downstream, first in your small bowel, then your that ends into your large bowel. But stomachs are actually too big and hold too much food right now. The reason diets don't work is if you don't fill up your stomach, the inside of your stomach secretes a hormone called GREHLIN. It's nicknamed the hunger hormone. It secretes a hormone that gives you the hunger pains in your stomach. It tells your brain that you're hungry and makes you feel bad enough to go get food. The Snickers commercials call it feeling hangry. You actually can get angry from being hungry. Most diets that you're on don't fill up your stomach. If you drink Slim Fast for a meal, it doesn't fill up your stomach. It's liquid. It empties out of your stomach quickly. Your stomach is then empty, secretes GREHLIN, which makes you hungry and makes you feel bad. You do the cabbage soup diet, again, you usually don't fill up your stomach. It empties very quickly. You always have that hormone going, so you always feel bad. Diets, you lose weight. Most people can tolerate it for a month to 2 months because you are losing weight, but you're miserable doing it because that hormone is making you feel bad. What we want is an operation that helps cut off that hormone so you can eat a small amount of food without feeling hungry and without feeling hangry. First operation for this, and it's still kind of the gold standard, is the Roux-en-y gastric bypass. In the Roux-en-y gastric bypass, we operate on your stomach. We cut off part of your stomach, which is then called the pouch, and attach your intestine to it. The gastric pouch holds about 4 ounces. But when you fill that up with 4 ounces, it turns off the hormone and cuts off your hunger, even though you've just eaten a small meal. So instead of filling up your stomach that's the size of a football, you're filling up a little pouch about the size of a tennis ball. The gastric band really isn't offered anymore, but many of you may already have a band in. The band went around the top of your stomach. We cinched it down to kind of like tightening up a belt around you to make a little pouch, which again is about 4 ounces. For some reason, however, though, the band doesn't turn off the hormone GREHLIN, so people remained hungry, people remained feeling bad, didn't lose much weight. The average weight loss across the country was about 34 pounds, and that's not worth having surgery for. So we don't do bands anymore. In fact, people with bands, we're trying to get those out and convert them to a gastric bypass or a sleeve, and we'll be happy to see you in the office to discuss that as well. By and large, most of the operations done for morbid obesity these days are called the gastric sleeve. The gastric sleeve, we actually remove some stomach. We leave the portion of the stomach that's kind of dark colored there, kind of shaped like a banana. It's called the sleeve. That again holds about 4 ounces and turns off the GREHLIN hormone when you fill that up. A little less surgery than the gastric bypass. We're not operating on your intestines here. We're not sewing the intestines up to the stomach. We're taking off the side of your stomach. A little less surgery, which is always a little less things that can bother you and a little less things that can go wrong. We'll talk about, since it is surgery, everybody wants to know about the complications. All procedures, whether you're going to surgery here or going to the dentist or anything, carry the complications certainly of death. But most common are bleeding and infection. Well, we really don't have much trouble at all with bleeding from these operations, but it's always a risk. So far as infection goes, you get a dose of antibiotics before surgery, and you get antibiotics while you're in the hospital as well to cut down on any chance of infection. A leakage is where we've cut the stomach, whether it's the gastric bypass or the sleeve, and where we suture it back together, whether it leaks between there or not. We actually check it during your operation for a leak. I actually put air in your stomach, put water around it, look for bubbles, kind of like a nail in a car tire. When all that's good, we suck that out. The next day you go for an x-ray where you have to have an x-ray, again, looking for a leakage. Very rare to have a leakage, but we need to know about it if you do, and we need to know early on to keep you on the antibiotics and things like that. A stricture is where we've operated on your stomach and it tightens up, a little more common with gastric bypass where we sew the intestine. If it does stricture, sometimes the swelling will go out on its own. Sometimes we have to send you to the gastroenterologist who dilates it up a little bit. Not so much of a problem with the gastric sleeve. Internal hernia, again, is particularly involved with the gastric bypass, not with the sleeve, and that's because where we operate on your intestines, by moving them up and sewing them to your stomach, they could get twisted and get a small bowel blockage in that regard. And then, of course, we have vitamin deficiencies, again, more common with gastric bypass. All these complications we're talking about are less than 1% of cases, so 1 out of 100 get one of these things. But we put everybody, whether you've had a gastric bypass or a gastric sleeve, on vitamins after surgery. You take them once a day, and that usually is sufficient. Dumping syndrome is only related to gastric bypass. Many of y'all have heard the term, and that's why I wanted to cover it here. Dumping is when food leaves your stomach into your intestine too quickly. Normally, before these operations, you have a little muscle at the bottom of your stomach that opens and closes, kind of like the shutter on a camera that lets the food go slowly into your intestine so it can handle it and it can digest it. When we take the intestine in a gastric bypass and sew it directly to the stomach, there's no muscle there to control it. If foods, primarily carbohydrates, things that you probably shouldn't be eating that many of anyway if we're trying to lose weight, if they go into your intestine rapidly, they will make your intestines irritated, make them cramp. Sometimes you break out in a sweat, and then it's usually followed by kind of explosive diarrhea. Dumping isn't all that horrible though, because it is most common with high carbohydrate loads, and if you go and try to eat a bowl of Bluebell ice cream, you may get this, which is bad, but in the long run it kind of teaches you not to eat too much of that stuff because it may affect you after a gastric bypass. After the surgery, whenever we operate on stomachs or intestines, they swell closed when they swell a little bit. If you happen to hit your head and get a goose egg, it swells out. If you sprain your ankle, it swells out. But intestines and stomachs will swell closed, and right after the surgery, food could get stuck. So we send you home on a liquid diet. A little bit of the swelling comes out. You get to start on soft food like scrambled eggs, grits, mashed potatoes. A little bit later, some more swelling comes out. We do mushy things like things that butter beans, black-eyed peas, things that are a little mushy. Eventually, you should be able to eat any type of food, including chicken or steak. We ask a couple of things: cut the bites small, chew them very well, and eat slowly. The whole purpose of this diet is to eat slow as well, because that GREHLIN hormone we talked about before takes 20 minutes to turn off after you start eating. So we need a meal to last at least 20 minutes. Even though the meal is the size of a tennis ball, it needs to take at least 20 minutes, so when you finish, the hormone is turned off, you're not hungry, you won't overeat, you won't come back to the kitchen 15 minutes later because you're still hungry. If you eat nice and slow, things will go through, and you'll have very little trouble after one of these operations. So at that point, this is basically it. I'd like to add one other thing. We do this surgery laparoscopically and robotically, which means we do it through little puncture holes about the size of a big pin rather than making a big incision to get my hands in there. Much less pain, much quicker healing, much less chance for a wound infection. I put stitches when I finish where those little puncture holes are that are completely in the skin. You don't even see them, and they dissolve. So when you go home, it's just you. Bandages are off. You don't have any drains or tubes or anything. You can be taking showers. You can be out and about. We see you back in the office for regular post-op visits, but we won't have to take out any stitches because they're actually inside and they dissolve. Very good cosmetic look. People really won't notice a big scar on you. They kind of fade away and are pretty hard to see. I know for y'all this is a big step. Most of y'all have been researching this. The average is even up to 2 years, reading on the internet, asking friends. Many of y'all have had family and coworkers and friends have the procedure, and you're interested. We'd like to see you in the office and discuss it with you further. Get things set up. There are a lot of requirements from the insurance company, and we'll go over all those and work you along and get you approved for this surgery. So with that, I'd like you again to thank you for coming out tonight.